All right. Thank you, David, for the warm introduction. As I connect, I would just like to say that the data that I'll be presenting really showcases in many ways ongoing research from the bench to the bedside from our dynamic division of bone marrow transplant and cell therapy. And as you see from the title, I'll be talking about insights from administering CAR-T cells following allogeneic hematopoietic cell transplant. And as David mentioned, the work that started in the lab and sort of the insights from the lab that we have now translated to the clinic. Here are my disclosures. So for today's talk, I will be going through several different topics that you will see how this narrative connects over the course of this presentation. So I first want to give a brief overview of CAR-T cells for B-cell acute lymphoblastic leukemia. As David mentioned, my colleague Matt Frank gave a really nice talk on CAR-T cells a couple months ago here for Grand Round. So I'm going to focus really just on what's germane to B-cell ALL. I'll then talk about graft engineering for allogeneic hematopoietic cell transplant. What is that? How do we do it? What are some of the enhancements that we're able to engineer from graft engineered allotransplant? I'll next then dovetail into this phase 1 clinical trial, BMT-378, that combines allogeneic hematopoietic cell transplant and allogeneic CAR-T cells for high-risk B-cell ALL. And I'll discuss just the interim outcomes from that study. And then finally, I'll highlight the impact of the intestinal microbiome and CAR-T cell therapy. So first, CAR-T cells for B-ALL. I'm showing you here all of the CAR-T cells that are currently approved. CD19 CAR-T cells are currently approved for B-cell indications. And I just want to walk you through these CAR-T cell constructs. So this is the construct or the vector design of these CAR-T cells. And you can see up above the names of them. So axicell for short, brexicell, tisacell, lysacell, and obicell. All of these currently available products utilize autologous T cells. So T cells from the patient with disease, either lymphoma or leukemia, that are engineered to express the CAR and then given back to them. So they're all autologous CAR-T cells that are currently FDA approved. All of them use signal 1 from the T cell receptor endogenous signaling, signal 1, which is CD3 zeta. And they all have a co-stimulatory domain. So here you see 2 co-stimulatory domains listed, CD28 and 41BB, which is also mimicking the T cell receptor signaling in its endogenous context. There are a few distinctions that you note. The transmembrane domain is either CD28 or CD8, which has functional implications. And most recently, all of these CAR-T cells had a binder or a single chain variable fragment that bound the antigen that was FMC63, except for this newest CAR for B-cell ALL that was just approved in November of 2024, obicell, which has the CAT scFv. And various kinetics have found that this scFv has a quicker off rate, which has functional implications for its activity. So as I mentioned, these CARs are all approved for indications including non-Hodgkin's lymphoma, whether large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, as well as B-ALL. So I want to hone in a little bit more specifically on those approved for B-ALL. So again, brexicell, tisacell, and obicell. For patients with large B-cell acute lymphoblastic leukemia whose disease relapses after frontline therapy, they may be candidates for CAR-T cell therapy. But with these first 2 CAR-T cells that were approved, the median duration of response was about 6 months or less. That's different from the initial data that we see from the clinical trial for obicell. It's about 14 months progression-free survival median duration. So we'll see what comes with that. But in general, we know that with our CAR-T cells that were initially FDA approved, that they don't lead to durable remission, and many patients relapse. In this context, it's not uncommon for patients to receive CAR-T cells as a bridge to an allogeneic transplant, just to give you an idea as to the limited remission that we see with these therapies. And one of the reasons why these CAR-T cells relapse, what we know from the literature, is that about 50% of patients will lose the expression of CD19. So these CARs target marker on the tumor called CD19, and you can see the low event-free survival and overall survival. Even though patients have an early response, the disease remission is not durable. And looking at this representative FACS plot, prior to the treatment with a CD19 CAR, patients have really high expression of CD19, CD22, but then you can see the CD19 is lost. And that happens in about 50% of patients who receive these CARs. For that reason, several years ago, the group from Stanford translated a CAR that was developed in the Mako lab, a CD19-22 CAR, a bispecific, to the clinic in a clinical trial that was led by Dr. Miklos and Dr. Mako. They evaluated patients who received this CAR for indications including lymphoma and leukemia. And I'm showing you the data for the patient, a representative patient treated with leukemia. You can see prior to infusion that the patient was, had very extensive disease on this MIP image on the PET, and 6 months post, the disease had eradicated. But when we look at all the patients who were reported on this clinical trial, 17 patients that were reported, there was 100% objective overall response and 88% CR. However, again, when you look at the median progression-free survival, it was only 5.8 months. So the rationale for designing this CD19-22 CAR was to use targeting by 2 antigens with the hope that that would limit antigen loss. At least in this study, that didn't occur. We know that from further analysis that this trial really, or this CAR really signaled predominantly through CD19, and the signaling through CD22 was not as robust. Nonetheless, early data from CARs for B-cell ALL show that we still have a lot of work to do and biology to fully uncover. Now let's talk a little bit about graft engineering. And what it is and how it's used in the setting of allogeneic hematopoietic cell transplant. So allo-HCT is a therapy that's used for patients who, with hematologic malignancies, many of whom don't respond well to upfront chemotherapy. It entails conditioning regimens with total body irradiation, chemotherapy, and sometimes antibodies to condition the recipient, after which the recipient receives donor hematopoietic stem cells. And what we know about conventional allo-HCT is an allo transplant where the cells are collected from the donor, and all of the cells, without discriminating or filtering or selecting for any cells, all of the cells from the donor are given to the recipient. So this doesn't entail the removal of any T cells or other cells that could be of concern. And in this context, the grade of acute graft versus host disease, which is where T cells from the donor can recognize various tissues within the recipient as foreign, whether that be the gut, the skin, the liver in the acute setting. The rate of acute graft versus host disease is about 40 to 60% in this context. So as a question for investigation and improving allo transplant, we know that giving all these donor T cells is something that we want to limit, so we can limit graft versus host disease. But to give you a little bit more information in terms of insights post-transplant, relapse and graft versus host disease are the leading causes of mortality following allotransplant. Here's a pie chart from CIBMTR, which reports out all the data nationally from transplant centers. And in blue are the patients who relapse in the first year post-transplant, so 56%. And the light brown is graft versus host disease. So the tan, so you can see that both relapse and graft versus host disease contribute to a significant amount of mortality in the year following allotransplant. So much of the allotransplant research for this reason is really focused on addressing these two post-transplant complications, relapse and graft versus host disease. So how can we enhance graft versus leukemia, which is really what the T cells provide, but how can we limit or mitigate graft versus host disease, which is also modulated by alloreactive T cells within the graft. So the T cells are important, but we need to balance that relapse and GVHD. So for that reason, graft engineering entails enriching or removing cells from an allotransplant, as David just briefly touched on. So a couple strategies for graft engineering really look at one of these two buckets. So decreasing graft versus host disease. Current data in our field looks at in vivo T cell depletion, and one of the most common methods of in vivo T cell depletion that we currently use is the use of post-transplant cyclophosphamide, or PT-Cy, and I'll talk a little bit about that, but PT-Cy removes that rapidly expanding subset of alloreactive T cells that are present post-transplant in order to decrease GVHD. Abatacept is another strategy, and then there are also methods of ex vivo T cell depletion. So before we give the donor T cells, we remove certain products. So either certain T cells, either through CD34 selection or alpha beta T cell depletion or Treg enrichment. And I'll be focusing in the latter part of the talk on the Treg enrichment and the data that came from the Negrin lab. The other approach to really consider when we're thinking about graft engineering is enhancing graft versus leukemia activity. So strategies to enhance graft versus leukemia activity have looked at cytokine manipulation, antibody drug conjugates, and also genetically modified T cells. So adding back genetically modified T cells post-transplant, whether CAR-T or T cell receptor T cells. And for the purposes of the discussion today, we'll be honing in on the addition of CAR-T cells. But before we do that, I want to talk to you a little bit about post-transplant cyclophosphamide, or PT-Cy, and the data that we see with in vivo T cell depletion. This data on PT-Cy was really, I would say, quite notable in the last few years. One of the key advances in allogeneic transplant, published in New England Journal in 2023. There was a randomized study, a very large randomized study, that looked at the experimental prophylaxis of cyclophosphamide, tacrolimus, and mycophenolate mofetil post-transplant versus the standard of tacrolimus and methotrexate to prophylax against graft versus host disease. And here you can see in the blue standard prophylaxis, looking at the number of patients who had GVHD relapse-free survival, which is a common endpoint in many transplant studies. You can see the GVHD-free relapse-free survival was lower with the standard prophylaxis compared to the approach that incorporated cyclophosphamide. As we were, thinking about sort of the standard of care, we also looked internally at our Stanford data of patients who had B-cell acute-lymphoblastic leukemia and received a PT-Cy transplant. You can see that early on, we still do see a significant number of relapses following this PT-Cy containing regimen, with 61% relapse-free survival at 1 year. Again, highlighting that we need to improve upon our graft engineered strategies, that although the GVHD risk is lower, relapse remains an ongoing concern. Another approach to graft engineering, as I just alluded to, that emerged from the Negrin lab was first published in 2003 in Nature Medicine by Dr. Negrin and his colleagues. And here they used a preclinical model, a mouse model, and this mouse model was an MHC disparate mouse model. So in the transplant mouse models, we use models of mice are very HLA disparate to use, MHC is analogous to HLA in mice. And so we use models where we know that GVHD will develop so that we can then use strategies to see how we can reduce graft versus host disease. So they use the MHC disparate model of B6 into BALB/C mice. And you can see that when they gave conventional B6 T cells, that all of the mice, you can see, died due to graft versus host disease. This is the open circle. However, the closed circle, they added to that MHC disparate model regulatory T cells. And you can see that the regulatory T cells enhance survival. And looking here at bioluminescent imaging, these T cells were luciferase labeled so they could be evaluated by bioluminescence. And you can see that there was decreased expansion of the T cells when the Tregs were added. And this representative figure shows you the conventional T cells, those that induce graft versus host disease. The mouse lights up and likely very soon after this succumb to graft versus host disease. Whereas in the mouse that received conventional T cells and regulatory T cells, or Tregs, there was attenuation of graft versus host disease due to suppression of alloreactivity with the addition of the regulatory T cells. This was a really important advance in subsequent studies and in the lab led to the translation of this insight to a clinical trial and clinical development, led largely by Dr. Everett Meyer in the bone marrow transplant division, and now in this protocol that's coined Orca-T. So in this approach of graft engineered allograft, Orca-T, we give myeloablative conditioning at day minus 10 to day minus 2. And then on day 0, patients receive the stem cells and regulatory T cells. And then on day 2, they receive conventional T cells. The Tregs and conventional T cells are given at a 1-to-1 ratio, and they work that out over many studies. And then on day 3, patients receive single agent tacrolimus. So in comparison to the PT-Sci data that I showed you, where we generally give more than one agent for pharmacologic GVHD prophylaxis, in the Orca-T graft, we can give one agent for prophylaxis, and that's tacrolimus. And with the Orca graft, recently published in Blood, we see low rates, excuse me, low rates of graft versus host disease among these recipients. So acute grade 3 or greater graft versus host disease is around 7% compared to the standard of care, 22%, and moderate to severe chronic graft versus host disease, 11% compared to standard of care. So showing that this approach does lead to decreased graft versus host disease, both acute and chronic. So now getting to thinking about enhancing outcomes for patients with high-risk B-cell acute lymphoblastic leukemia. As David mentioned, we thought about combining this myeloablative conditioning, graft engineering, and CAR T cells. And the rationale that really led to the thought that we should combine was really in large part guided by scientific insights from my postdoc when I was at Memorial Sloan Kettering, where we looked again in an MHC disparate model. I'm showing you the same mouse model, B6 and DEBALD-C. And here we gave a T-cell depleted bone marrow transplant and then an A20 tumor. A20 is a tumor that targets CD19. So we saw that in those recipients of the A20 tumor, they ultimately died of death from tumor. However, we also developed purely murine CAR vectors that could signal and have normal immunobiology in a mouse model. So these two vectors that I'm showing here are M19 delta, which is a control CAR that had a truncated CD3 zeta signaling chain, so it didn't really signal adequately. And then a second generation CAR akin to the ones I showed you at the beginning of the talk. What we found was that when we gave these control CAR T cells, mice died from graft versus host disease. However, in the recipients of the second generation CAR, there was anti-tumor activity as well as attenuated GVHD. As noted by this red line on the survival curve, you can see that the recipients of the second generation CAR had improved survival compared to the controls. And so that was really interesting because a lot of the data that is looked at the addition of T cells post-transplant using donor lymphocyte infusion has shown about a 30% incidence of graft versus host disease when T cells are added back post-transplant. So this was a bit paradoxical to what we would have expected. So we started to delve into mechanism. And I'm going to show you one more mouse slide, last mouse slide for the talk. So in this, we use luminescent T cells. So these are luciferase labeled T cells. We again monitor them by bioluminescence in the absence of tumor, use the same MHC disparate model. And what we found was that our control of M19 delta T cells expanded much more, as you can see by the flux plot, compared to the second generation CAR. And so then that led us to various questions. Are these CAR cells being deleted? Are they undergoing exhaustion? Why are they not expanding to the same degree as these T cells that have a non-functional CAR? And various mechanistic studies showed that the CAR T cells, the subset of alloreactive CAR T cells specifically, were having increased exhaustion, as noted by these various exhaustion markers, PD-1, LAG3, et cetera. They also had increased downstream TCR signaling, as noted by these phosphosites that are downstream of the T cell receptor. And transcriptomic analysis showed that there was increased gene expression of various apoptotic genes, suggesting that the alloreactive subset of these CAR T cells was undergoing exhaustion and activation-induced cell death, but the non-alloreactive subset was persisting and leading to improved anti-tumor activity. This is a really, really provocative insight. And so we decided to then look at the literature. There wasn't an exact corollary because there hadn't been any studies where CAR T cells had been given at the time of an allograft to prevent GVHD, but there was literature that showed patients who had relapsed post-transplant and received CAR T cells. So those we classified as true allo, so donor-derived T cells, so essentially a patient who got a transplant, they relapsed, and then the investigators or their clinicians went back to their original transplant donor and engineered CAR T cells. So that was a good number of patients. And then there were other patients who got a transplant, relapsed, and then the recipient's tolerized T cells were used to engineer CAR T cells. And total, there were 132 patients that we assessed from the published literature at that time. And we again saw here that the incidence of acute and chronic graft versus host disease was around 3% compared to what I told you when donor lymphocyte infusions are often given post-transplant, more 33% or so incidence of graft versus host disease. So this suggested to us that the mechanism that we identified in the mouse model may actually be holding true here. So as David mentioned, when I was thinking about coming to transplant and he was recruiting Stanford and he was recruiting me, it was really exciting to me that he was also interested in allo CAR T and combining allo CAR T with transplant, and that would allow us to translate our preclinical insights to the lab. And so the perfect backbone, as I showed you already, Orca-T has a very low incidence of graft versus host disease. So it was really the perfect backbone for us to consider adding an engineered cell therapy. So I've already walked you through, so the Orca-T incorporates stem cells on day 0 as well as Tregs, TCONs on day 2, and we decided to add, after TCON infusion on day 2, donor CD19/22 CAR T cells, which I showed you early on in one of the early slides that when we gave those CAR T cells in the autologous setting, there was an incidence, a median duration of response of about 5.8 months. But we wanted to use this CAR construct as a proof of principle as to whether this approach might be one that we should continue to pursue. Other important notes to highlight in distinction to the Orca-T is that we did use single agent tacrolimus for graft versus host disease prophylaxis or GVHD pharmacologic prophylaxis, but we use a lower dose of tacrolimus at 5 to 7 nanograms per mil compared to, we usually go up to 10 in this early transplant setting. And the reason for that, and I include the citation here, there is some early preclinical data that suggests that tacrolimus suppresses CAR-mediated cytotoxicity. So we wanted to balance that by keeping tacrolimus on board, but not limiting the effectiveness of the CAR T cells. So for this clinical trial, my partner in this trial is Dr. Lori Muffley. She is the PI of the study. We developed the study together, and we've continued doing it to this point together, and it's really been a lovely collaboration. She's a seasoned clinical investigator, and it's been really nice to translate this data with her, and I'm the IND sponsor for the study. We use 2 cell collections from the donor. So I do want to walk you a little bit through that really important detail, which is that we use 2 collections, first a steady state leukapheresis for the CAR T cells, and then GCSF mobilized apheresis for the allograft engineering. And the reason why we do that is there is some data that GCSF mobilization, which we use pretty commonly for stem cell mobilization, that it can skew towards a Th2 phenotype. And so we did not want to use potentially Th2 polarized cells for engineering for CAR T cells. But I see Alfonso here, one of our fellows. He and I are going to be looking at these paired steady state samples and the GCSF engineered ones to really interrogate, are we seeing Th2 polarization post GCSF or not? And so we will delve into that a little bit further. So now to the rationale for the study. So our hypothesis is that for patients with high-risk B-ALL who receive a myeloablative Orca-T from a matched related or unrelated donor, that donor CD19/22 CAR T cells will augment graft versus leukemia and without increasing acute graft versus host disease or graft failure. So the primary endpoint for that is looking at day 42, incidence of engraftment without grade 3 to 4 GVHD. And we have some secondary endpoints of interest as well. So key eligibility criteria is we're including patients who are adults, have CD19 expression on their leukemia, and have high-risk disease features, and who have an available matched-related or matched unrelated donor. And we use a Bayesian dose escalation design using the keyboard approach. And here are the 3 dose levels. So the lowest being 1 × 10⁶ CAR-positive cells per kilogram, and the highest 3 × 10⁶ CAR-positive cells per kilogram. You'll see that it is a modest dose escalation, but because we're dosing on CAR-positive T cells, we wanted to be quite careful, considering that the transduction efficiency could potentially vary as we were designing the study. So here's the consort diagram for the study to date. So as David mentioned, I got here in September of 2021. We wasted no time in writing the study, and we enrolled our first patient in September of 2022. And from September 2022 to December 2024, we've enrolled 15 patients on this study. We've successfully manufactured CAR T cells for all 15 patients. One patient who we manufactured CAR for decided that he didn't want to get a transplant after all and hasn't got a transplant. And so for that reason, we have one patient that hasn't been treated. So 14 patients have received these donor CAR T cells on day 2 post Orca-T to date. And we have 14 patients who've reached the primary endpoint, and I'll show you a little bit of data about these patients thus far. So for baseline characteristics, so the median age of, B-ALL, we have a lot of patients who are adolescent young adult or young adults, and you can see the median age 33, ranging 21 to 58. 71% of the patients are Hispanic, which really tracks with the incidence of ALL and in our population in California. The high-risk disease features that we've noted in 40% of the patients include PH-like, or one of these abnormalities, KMT2A, TP53, or complex cytogenetics. 21% of the patients had CNS involvement, and 71 of the patients were MRD positive or minimal residual disease positive after induction. At the time of treatment on our study, 50% of the patients were MRD negative, and 43% were MRD positive, and there was one patient who had ongoing active disease. We have a mix of patients who received their transplant from a matched sibling donor, 86%, and then 14% from unrelated. And we have used TBI cyclophosphamide conditioning at myeloablative dosing, as you can see here. So first, for safety and efficacy, because it is a phase 1 clinical trial. So the safety and efficacy, we haven't seen any delays in either neutrophil or platelet engraftment. There has not been any incidence of acute or chronic graft versus host disease in the patients treated on this study. And the CAR-mediated cytotoxicity has been low. So low-grade cytokine release syndrome and low-grade neurotoxicity, only one patient who developed neurotoxicity. And in terms of the clinical outcomes for the patients on this study, I am stratifying them here by the dose levels, so dose level 1, 2, and 3, as well as an expansion cohort at dose level 3. And what you can see is the initial baseline characterization in terms of minimal residual disease. So this highlights the closed circles, those patients who had minimal residual or active disease prior to treatment on the study. And as we look longitudinally, our oldest patients treated on the study are beyond 2 years, and all patients remain in a minimal residual disease negative remission by conventional standards, including BCR-ABL and flow cytometry. However, these closed circles here highlight positive disease, minimal residual disease positive by clonoSEQ, which is a next generation sequencing assay. So our median follow-up time is 304 days with over 6 patients with over 12 months of follow-up. And to date, we have not observed any dose-limiting toxicities, no deaths, and then these 2 MRD positive by clonoSEQ or next-generation sequencing. We, as I mentioned, we also we're looking at graft engraftment or risk of graft failure. Here you can see the whole blood chimerism, so how much of the whole blood is the donor cells. So the donor chimerism for whole blood and CD3, you can see, has been quite prompt and robust in all of our patients. We haven't seen any prolonged cytopenias, so I'm showing the white blood cell count, neutrophils, and platelet. And so after this therapy, we haven't seen any prolonged cytopenias following treatment or the incorporation of these donor CAR T cells. So I want to talk a little bit more about some of the correlative analyses from the study and highlight our CCSU researcher, Bita Sahaf, and her team, who help us with a lot of this analysis of the correlative studies for the clinical trial. Alfonso Molina, who's here in the audience, who is a really dedicated Hem-Onc fellow, who's helped us with the analysis of the study. And then one of my postdocs, Jai Z, who has really been involved in the computational analysis as well. So first, you might be wondering about the CAR T cells, and have the CAR T cells in this context persisted. So I'm showing you the CD4, CD8, and total CAR T cells. And in the individual lines of patients, this is a longitudinal follow-up, you can see that even beyond 2 years, that the CAR T cells are still persisting above the limit of detection, which is really quite impressive. That subset that's persisting seems to be predominantly CD4 as compared to CD8, but we still do see CAR T cell persistence by our CARFAX assay, which is an assay panel for flow cytometry that we commonly use not only for our clinical trials, but also for our commercial CAR T cell patients. Next, I'm showing you the quantification of the CAR T cell persistence, expansion and persistence by qPCR. And again, you can see that we see quantifiable levels of CAR T cells above the limit of detection for still beyond in those longer time points. And so in summary, for this first portion, I want to highlight that we've successfully enrolled 15 and treated 14 patients on our single center phase 1 study incorporating an engineered allograft, Orca-T, and donor CD19/22 CAR T cells for adult patients with high-risk B-ALL. Among the 14 evaluable patients, none developed acute or chronic GVHD or severe CAR-related toxicity. Additionally, all patients achieved a flow and or BCR-ABL MRD negative complete remission, except for 2 subjects with low-level clonoSEQ MRD positivity. And correlative data demonstrate that donor CD19/22 CAR T cells persist beyond 1 year. So now as I pivot to the next phase of the talk, I do want to talk to you about some other correlative insights that we seek to investigate. So first, one of the things that we're really interested in interrogating is the impact of tacrolimus on the CAR T cell persistence. Here is a paper that did a screen of over 500 drugs in the in vitro setting and looked at how these drugs impact CAR T cell cytotoxicity, so those that enhanced CAR toxicity, and then those that inhibited CAR cytotox. And tacrolimus, here circled in red, was the 4th most suppressive to CAR-mediated cytotoxicity. Dasatinib, we have some patients who've received ponatinib, and dasatinib was among their also suppressed CAR cytotoxicity. So one of the things we do plan to do is develop a mixed effects model to evaluate. We have all the tacrolimus levels, we have the duration of ponatinib, so we will be evaluating how tacrolimus could be impacting the persistence. Maybe it's, there is some data also looking at how tacrolimus diminishes T cell exhaustion, so perhaps these CAR T cells are more fit because of exposure to tacrolimus. These are things that we're not only looking at with our correlative data, but we are also investigating in a mouse model in the lab. So now I do want to pivot a little bit to talk about microbiome analysis and highlight Sarah Elkordi, who is an LSRP in my lab, who really diligently collects our stool samples from patients not only on BMT-378, but also our commercial CAR T cell recipients. Alicia Darwin and Ishan, who are internal medicine residents, who've worked with us on microbiome studies, both with collection of data as well as studies in the lab, and then again, one of my postdocs. So this will focus in the last section on what our insights have shown in terms of the role of the intestinal microbiome or impact on CAR T cell outcomes. By way of overview, I would just like to say that there is well over a decade of literature that has highlighted the impact of the intestinal microbiome on allo-HCT outcomes, and have identified that the microbiome and dysbiosis induced by antibiotics and other medications is associated with increased acute graft versus host disease, antibiotic resistance, relapse, etc. There's also emerging data that suggests that this intestinal microbiome dysbiosis is also associated with decreased progression-free and overall survival, as well as increased neurotoxicity in the post-transplant setting. And so I'm just going to go a little bit over some of that data as we seek to, develop deeper insights, but also we are going to be analyzing that in the context of this clinical trial. I think it's just important to end on that note. So I was at MSK when I also led a study that looked at the role of antibiotic treatments before infusion. And we looked at a subset of antibiotics that target obligate anaerobes, piperacillin tazobactam, imipenem, and meropenem. And we found that exposure to one of these PIM antibiotics that are often used for the treatment of neutropenic fever, that they were associated with decreased overall survival and also increased neurotoxicity in the post-CAR T cell setting. This was really interesting, and as I came and started my lab, we started developing mouse models to really interrogate the mechanism behind not only the impact of antibiotics on the efficacy of CAR T cells, and we're also now looking at the impact of antibiotics on the development of ICANS. But interestingly, we published this in 2022. In 2023, a group of investigators from both the United States and Germany published a study that really corroborated those findings, looking at piperacillin tazobactam, meropenem, ceftazidime, and cefepime, which they categorized as high-risk antibiotics. And here you can see they looked at the proportion surviving, and those patients who were exposed to high-risk antibiotics, here in yellow, had a much lower proportion of survival. And they also had higher incidence of the neurotoxicity ICANS. So that was, quite interesting that, a separate cohort of similar CD19 treated CAR T cell patients had a similar outcome in terms of this association. We also looked in our paper at cefepime, because cefepime is another antibiotic that's often given for neutropenic fever for our patients, but it doesn't target obligate anaerobes to the same degree as the PIM antibiotics. And we had a small number of patients who received cefepime, but we found that cefepime did not limit progression-free survival or overall survival. And that was a really important question to ask, because when we saw the initial antibiotic data, we couldn't help but wonder, were the antibiotics really just a surrogate for a sicker patient who received antibiotics and did worse, as compared to highlighting some microbiome impact? And the cefepime data suggested that really it wasn't just antibiotic exposure, but the specific antibiotic and what they were targeting in the gut. And recently, at the latter part of 2024, another paper came out where they evaluated no or low risk antibiotics, cefepime or anaerobe targeting antibiotics. And they again affirmed that cefepime, exposure to cefepime in the post-CAR T cell setting, did not decrease survival to the same degree as an anaerobe targeting antibiotic. So again, independent validation in a separate now third cohort. Another thing that we've looked at in our microbiome data is how baseline pre-infusion samples, so bacterial taxa, as well as metabolic pathways that they utilize, how those are associated with CAR T cell outcomes, and I'm highlighting a few of them here. And there's been quite a lot of overlap with the bacterial taxa that we've identified, as well as in this separate cohort of patients, not only from Germany, but also from China, identifying similar bacterial abundances that are present in recipients of CAR T cell and maybe biomarkers of response. So in our ongoing studies, not only on the clinical trial, but also for our autologous CAR T cell patients, we're collaborating with Dr. Tessa Anderman, who was a postdoc in the lab of Ami Bhatt and an ID fellow here now at UNC with her own lab. And we're collecting robust REDCap data, looking at infectious complications, immune reconstitution, post-CAR T, and also banking microbiome samples, for which we are performing metagenomic shotgun sequencing and really digging a little deeper to analyze how the microbiome may modulate immune reconstitution, persistence and expansion of CAR T cells, and looking as well at these peri-antibiotic exposures. So not just thinking about antibiotics before CAR T cells, but also the 4 weeks after. So peri, we've looked at these any antibiotics in the peri window and see that they do diminish overall survival. But when we look at peri-anaerobe antibiotics, the overall survival is more notably diminished. When we look at a feature of the intestinal microbiome, alpha diversity, which is the diversity within a sample, higher alpha diversity is more just basically suggests that there's different types of microbes or more different types of microbes within the gut, and it's been identified as a marker for a healthier gut. We see that in our patients exposed to peri-anaerobic antibiotics, that their alpha diversity is lower, has a much lower nadir, and takes longer to recover compared to those with with no peri-anaerobic antibiotic exposure. And so, in some of our insights have suggested that favorable microbiota may have an important role in enhancing anti-tumor activity, diminishing toxicity, but unfavorable microbiota diminish anti-tumor activity and increase toxicity, such as ICANS, as we suggested. Some of the things that we've highlighted and that have been substantiated are that decreased diversity, both alpha and beta diversity, are features of a dysbiotic microbiome in the post-CAR T cell setting, that there's increased dominance of specific bacterial taxa in this setting, a disrupted mucosal barrier, as well as modified MAMs and metabolites. So in sum here, exposure to broad-spectrum antibiotics in the weeks before CAR T cell infusion is associated with decreased progression-free survival, lower overall survival, and increased neurotoxicity. 16S and metagenomic shotgun sequencing revealed bacterial taxa and metabolic pathways associated with CAR T cell efficacy, and now multiple clinical cohorts suggest overlapping intestinal microbiome findings. Ongoing preclinical studies in my lab are evaluating regulatory mechanisms, because now we have really robust data to support these associations, but we're delving into how the microbiome is modulating these responses. So in conclusion, I hope I've shown you that allogeneic CAR T cells can enhance graft versus tumor activity after a graft engineered allotransplant, that interim data from BMT-378 suggests that a similar approach could be considered for other hematologic malignancies, such as acute myeloid leukemia or multiple myeloma, to induce longer remissions for patients, and correlative analyses from the study, including persistence and expansion of CAR T cells, as well as intestinal microbiome analyses, will provide further insights for future development. With that, I would like to acknowledge several individuals. First, our bone marrow transplant and cell therapy division, which has supported this clinical trial that I've discussed from the beginning to the end. My partner in the study, Dr. Lori Muffley, Dr. Miklos, Dr. Negger, and Dr. Meyer, Dr. Makel, and then again, Alfonso and Sneha, who've really been intricately involved in the analysis of these patients. Our BMT-378 research team, all listed here, our clinical research coordinators, our investigators, regulatory specialists who've helped us, manufacturing, which is done here at Stanford by LCGM and led by Dr. Steve Feldman, CCSU with Dr. Bita Sahaf and her team that works to analyze all these samples, our statistical core, Orca-Bio and the National Marrow Donor Program that have helped us with this, as well as for the microbiome studies, Dr. Bott, who's been a great collaborator since my time here at Stanford, and all of the individuals listed here, including our outside collaborators and my lab and funding sources. Thank you.
Great. We'll start with questions. Else, all right.
Thank you for an excellent presentation. Are you controlling for diet in your patients post-transplant?
No, we're not controlling for diet. I would love to do a diet randomization study, but that certainly would require a lot of funding. I am partnering with an investigator here who did a diet randomization study for another subset of patients, and we're in the process of soon analyzing that data, and we're hoping to glean insights from how we can do that, because a couple ways that you can control for diet would be to randomize patients to different types of diet, whether high fiber, high fermented, et cetera, or to use a diet tracking app to evaluate the diet, but that definitely would require some support for the patients to collect that data. But diet is very important in terms of microbiome, but it's something that we'd like to do, just haven't done yet.
You may, if you haven't, want to interface with Mike Schneider's lab, who's doing all types of diet studies and characterization of diet phenotypes. Be interesting to see how that can play out. Thank you.
Thank you.
Thanks, Melody. That was so great. I'm wondering two questions. One, have you stopped using cefepime then? And do you want us to stop using it in D1? And two, it sounds like you think primarily this is an issue of the microbiome and the profile of gut microbes, and a change in the anaerobic profile population rather than blood-brain barrier that leads to ICANS. Did I understand that right?
No, so it's certainly, it's actually both, I believe. And we're interrogating that now in our mouse model, but it's really too early for us to say. But I hypothesize that the exposure to these anaerobic targeting antibiotics might modulate the gut-brain axis. And already in the setting of ICANS, there's a leaky gut-brain, blood-brain barrier. So it could be that these anaerobic antibiotics are releasing metabolites that could be altering that. We have a collaboration right now, partnering with Michelle Manji's lab, where we're looking in a preclinical model. My postdoc who's working on it is sort of in the early stages of it, so still too early to say. And then to your first question about should we not be using cefepime, I think this data is strong data to really suggest that. I want us to really talk with our infectious disease ICID colleagues to incorporate them into that decision-making process. But this data seems really strong that cefepime should maybe be the front line for our patients.
I asked it backwards. We should prioritize
cefepime. Yeah.
I have a question about you said CAR T cells can persist beyond 1 year, right? So I was wondering if the B cell reconstitution and also the level of humoral immunity can be lower. So, and also its complications. Another one is the clinical trial in Europe matched related and unrelated matched donor. So I was wondering why in unrelated donor the instance of GVHD is still very low, and also it can apply to a hepatoidentical transplantation.
Okay, so first to address your first question about how humoral immunity is impacted in BMT378, where we're giving the donor CD1922 CAR T cell, and what is our data in terms of B cell aplasia. So we have six patients who are beyond 1 year. 5 of those 6 patients beyond 1 year still have no B cells. So we do see that there's ongoing B cell aplasia in many of these patients, and we do plan to compare immune reconstitution data from this study to those patients treated with Orca-T alone. And so that is something that we'll need to continue to monitor for, and also thinking about risk as it relates to infectious complications. That's something else that we will analyze in these patients compared to the Orca-T control cohort. So that was your first question. And then the second one in terms of have we evaluated haplo, and also why do the matched unrelated donors still have no GVHD? So these matched unrelated donors are 10 out of 10, or fully matched. And so Orca-T has data both with matched unrelated and matched related. And so this data, because it's a fully matched donor, matched unrelated, that's not surprising that there's no graft versus host disease there with this transplant context. There isn't data yet that we have done for haplo, but as we think about future implications for development of a future study, we are thinking about incorporating mismatched patients for a next step.
Might jump over to online here. Dr. Hun says, thank you for the talk. What are your thoughts regarding CAR NK natural killer cells, given their off-the-shelf advantage, less in risk of graft versus host disease? In the same vein, any updates on logic-gated CAR T?
Yeah. So CAR NK cells. So there is data on CAR NK as a strategy, to use as an off-the-shelf. There are various off-the-shelf strategies that have been investigated. CAR NK is one of them, gamma delta. But the issue with many of these non-conventional T cells that have been used for CAR engineering is that there's limited persistence. The toxicity profile for CAR NK has been quite low, but the persistence of the cells has been an issue. And so more to come, I'm sure, from there. There's trials looking at that. And then for logic-gated CAR T cells, so logic-gated CAR T cells are where you can, look at a CAR that binds to a if-then, like basically looking at 2 antigens, and in the presence of 2 antigens, the CAR binds. We haven't looked at that in this context. I think logic gating and some of these Bayesian logics for CAR T cells are really exciting, but nothing yet that we've brought forward to the clinic.
Dr. Georgie asks, given the impact on gut microbiome on progression-free survival, overall survival, et cetera, does probiotics or fasting, et cetera, have any role in the peri-infusion period?
Patients ask me that all the time. When I see them in clinic, they're like, I saw the paper, should I be taking probiotics? I didn't show it here today, but there is data it was a paper in the cancer immunotherapy space, but looking at anti-PD-1 therapy, published by Jen Wargo's group many years ago, where they evaluated patients who used probiotics in the anti-PD-1, in the anti-PD-1 setting, patients with melanoma, and they found that those patients who used probiotics actually did worse. So what I often counsel patients is that probiotics are not regulated. They vary widely in terms of what bacteria are there, what's the representation of those bacteria. I think more important is to think about dietary interventions, as our first question alluded to, because data from many labs here at Stanford, including the Sonnenberg lab and others, have found that diet rich in fermented foods, diets high in fiber, those produce prebiotics in the gut that are important for modulating and enhancing the microbiome, I think, more than a probiotic that you really don't know what you're taking.
Eat healthy.
Yes.
I love it.
Yes.
Dr. Smith, thank you so much. That was perfect timing, perfect, wonderful presentation. Lots of great comments on amazing stuff you're doing. Thank you for opening up this month. Please help me in. Thank you.
Okay.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.